I'm Dr. William House. At the House Ear Institute, we have been interested in the study of acoustic neuromas since 1961. Over the years, we have accumulated a large series of tumors, and recently, Dr. William Hitzelberger, the neurosurgeon who cooperates with us in the management of these cases, compiles statistics on all of our cases since the beginning of our experience with acoustic tumors. Over the years then, actually we have done 1,667 cases through March of 1984. It's of interest that in our area, Los Angeles, and I think in the United States in general, about 10% of our population are black. However, only a very small percentage of cases were black. Therefore, acoustic tumors do not apparently occur with any degree of regularity in the black population. As far as I know, there are no other racial characteristics, though, regarding acoustic tumors. Now, this is a summary, then, of the numbers of cases that we have done by year. Up here would be 120 cases. In 1961, we only did 4 or 5, and then in 1983, we did about 125 cases. So gradually over the years, the numbers have increased as far as the number of cases we're doing. This is the numbers of deaths by 100 cases, so it breaks down between 100 and 1,600 cases. In our first 100 cases, we had 9 deaths, and then gradually over the years, the mortality rate has decreased significantly. Now, our total operative mortality for 1,667 cases was 30 deaths, or 1.8% for the total series. If we break those down then, as to the causes of the mortality, the anterior inferior artery syndrome, that's the ICA syndrome, 14 patients died because of occlusion of the anterior inferior cerebellar artery. Now, this syndrome was described by Simmons some years ago, and it consists of a phenomena in surgery. When the artery is occluded, the patient's blood pressure will rise dramatically. If there is spontaneous respiration, that will cease, and then there will be a sudden swelling of the cerebellum. Once this syndrome has occurred, I have not seen a patient recover. Usually they will survive for several days on assisted respiration, and a spreading thrombosis of the brainstem will then ultimately cause their demise. So this is the main reason why we have been able to decrease our mortality, is because with the use of the operating microscope, we have been able to see very accurately the position of this artery and carefully separate it away from the tumor, and only divide those branches that come off of the artery, the internal auditory canal branches, and simply cauterize those with bipolar cautery, but do not cauterize the main artery. This artery usually at surgery is pushed out of the internal auditory canal because it normally loops into the canal, and then as the tumor grows, it's pushed out and occurs usually just on the inferior and anterior part of the tumor. Now, as far as the other possibilities of or the other causes of this operative mortality, we had 9 patients who died from, or had hemorrhages and died from them. 6 of these were in the operative bed, extraaxial. We had 1 patient who had an intracerebellar hemorrhage, and several intracerebral hemorrhages, or 1, and an extradural hemorrhage in 1 patient. These were all, of course, discovered by autopsy. We had 3 patients who died from pulmonary embolus in the post-operative period. We had one cardiopulmonary failure. One patient today, I don't think this would have occurred because we had a large arachnoid cyst in the posterior fossa that we didn't discover until the autopsy. And today this would have obviously been seen on the CAT scan, and we would have been able to avoid the shift in the brainstem that occurred when we removed the tumor, and this cyst then caused a pressure. We had one GI hemorrhage which occurred in a patient who was on steroids and began bleeding from multiple petechial hemorrhages throughout the GI tract, and we were unable to control that. We had one patient who died from meningitis actually sometime after the surgery. Now, between case number 807 and 1373, there were no fatalities. So we were able to operate on 566 patients in a series without a fatality. The operative mortality since case number 700 was 4 deaths, so that this then means that we have an operative mortality of about 0.4%, which is, I think, our current operative mortality. Now this decrease in mortality represents then primarily the advantage of the use of the operating microscope. Now we feel that the mortality from all different approaches, whether it's Trance-Labyrinthian approach or suboccipital approach or whatever, has been greatly decreased by the use of the scope, because we're better able to see the surrounding blood vessels and to carefully manage them either with bipolar cautery or in some cases with packing with various types of hemostatic agents. But we're very sure then that the hemorrhage has been controlled because you can see the operative bed with a microscope. And these are the main reasons why we've been able to greatly decrease our mortality over the period of time that we've been working with these tumors. Now, in order to get a picture of what our current statistics are, we have studied 216 cases that we operated in the years 1980 and 1981. These are all of the cases that were operated during this 2-year period, and we then have a follow-up of a year on these so that we were able to determine how well they fared as far as facial nerve function, hearing, etc. Harvey Cushing once said that every operation has its par. And by this he meant that as the surgical procedures improve, so does the result of the surgery, but that it is important that all surgeons understand what the results should be so that they can compare their own results with this so-called surgical par. So we're giving you now, in this 216 cases, the surgical par that we are currently achieving as far as our own cases are concerned. Now, during these 216 cases, we had an average age of our patients of about 47 years. The male-female distribution was essentially equal, and left side and right side were also essentially equal. Now, we did a classification of these tumors, and we've divided them into 4 sizes. The small tumors are those that are confined entirely to the internal auditory canal. Then the tumors between 1/2 centimeter and 2 centimeter would be the medium-sized tumors. 2 to 4 we call large tumors, and greater than 4 are classified as giant tumors, because these tumors usually are associated with elevated pressure and other problems, so that they do fall into a rather special classification. Now, the breakdown then, we had 20 patients in this series, or about 9% were intracanalicular tumors. About 51%, half of them, were medium tumors, the 2 to 4 centimeter size. The large tumors were about 1/3 of the patients, and the remaining 9% were these giant tumors. Now, all of these patients were operated on through a Trance-Labyrinthian approach. what we do is to take out all of the bone over the posterior fossa, over the posterior half of the internal auditory canal. We skeletonize and collapse the sigmoid sinus, and we usually extend the bone removal posterior to the sigmoid so that you do get a rather wide view into the cerebellopontine angle. Now, as far as our removals with these cases, we were able to remove the tumors totally in all patients, with the exception of one patient where we did a subtotal removal on a planned basis. This was an elderly patient who had considerable unsteadiness due to her tumor, and we were concerned that she would break a hip or fall and have a serious injury from this. So we were concerned mainly in doing a destructive labyrinthectomy for her, and at the same time we did a subtotal removal. She has done very well since that time. Now, during surgery of these patients with the translabyrinthian approach, we had vital sign changes during surgery in 28 patients. Now, vital sign changes are where we see a sudden rise in blood pressure. In our case, during anesthesia, we have controlled respiration. So what we look for are changes in the pulse rate or the blood pressure, usually either a rise in blood pressure or a sudden lowering of the pulse, or possibly both at the same time. If this occurs during surgery, it's a warning to us, and we then will terminate whatever manipulation of the tumor is going on at that time. Usually it's either pressing the tumor against the brainstem or in some way compressing the ICA, the anterior inferior cerebellar artery. And if that occurs, if you cease doing that, then many times you can alter the surgical manipulation so that it doesn't continue to be a problem. In most cases, we're able to then carry on with the surgical procedure. Now, on our larger tumors and in elderly patients, we do use an arterial line. And during arterial monitoring in this way, the anesthetist can tell us from beat to beat whether or not there is a change in the pulse or the pressure. So it is a very accurate way of watching the vital sign changes, and we think it has helped a great deal in avoiding damage to the artery or to the brainstem because of this monitoring. Now, even in small tumors, you can have a change in vital sign. This particular patient had a large anterior inferior cerebellar artery that looped up into the internal auditory canal and was actually between the 7th and 8th nerves and the tumor. That's very rare. But when just beginning to manipulate the tumor at the lateral end of the internal auditory canal, we had vital sign changes, and of course then noticed this artery, and were able to dissect the tumor away from it and complete the tumor removal. In 1/4 of our patients that had the vital sign changes, that occurred during the removal of medium-sized tumors, and in most cases this is due to compression of the anterior inferior cerebellar by pushing the tumor against the brainstem. Now, in the large cases, this is where we usually have the vital sign changes, and here the vital sign changes can be due to pushing the tumor against the brainstem itself, and for this reason it's more common in this group of patients. In 21% of our giant tumor cases, we also had vital sign changes. In that case, though, there is usually a very extensive decompression of the center of the tumor, and for this reason many times these tumors are separated away from the brainstem with less problems in terms of compression of the brainstem. Now, our mortality in this group of patients was 1 patient, so that the mortality was 0.4%. The average post-operative hospitalization of these patients was 12.2 days. We do not use routine antibiotics on our patients, and only if the patient spikes a fever and has an aseptic type of meningitis, then would we use antibiotics. In this case, the hospitalization would be prolonged because it usually takes 8 or 10 days for the spinal fluid white cell count to come back to normal on antibiotics. So that averaging it all out, then the average would be about 12 days. Most patients would stay in 8 to 10 days, but those occasional cases that we have to treat for a longer period of time would bring it up to an average of 12 days. Now, as far as hearing preservation is concerned, I think it's now become very clear that it's not possible to save hearing in tumors that are larger than 2.5 centimeters. And in recent reports on attempting to save hearing, even during monitoring of the brainstem responses, apparently it's not possible to save hearing very often in acoustic tumors. And we have come to the conclusion in our own series that we only attempt to save hearing if the tumor is confined to the internal auditory canal and if the hearing is quite good preoperatively. By good, we mean less than 50 decibels of hearing loss and better than 50% discrimination score. If the hearing is poorer than this, then it is not worthwhile saving it, and generally the poor hearing, we feel, indicates that there is already involvement of the cochlear nerve or considerable compression of the internal auditory arteries that supply the inner ear. If that's the case, then we are not able to save hearing because we do have to damage further the cochlear nerve in removing the tumor, and also the arterial supply to the inner ear must be conserved, and in the larger tumors, greater than 2.5 centimeters, it's very rare that this artery is free of the tumor, and you can remove the tumor and still save the vessels to the inner ear. For this reason, in our own series, then, we only attempt hearing, as I indicated, in the small intercanalicular tumors. Now, when we did attempt to save hearing, and we attempted that in 10 of our patients, which was 5% of the series, we were successful in 4 cases. So of those that we tried to save hearing, we were successful in 40% of the cases. But in terms of the overall percentage of cases, only 2% of our patients were we able to save hearing and still remove the tumor. We feel that, at least at this particular time, this is probably as good as we'll be able to do in terms of saving hearing. Whether or not intraoperative monitoring will make it possible for us to do better on saving hearing remains to be seen. So far, the articles that I've read on this don't seem to indicate that the intraoperative monitoring gives any warning as to, or any indication as to how to manipulate the tumor and still save the hearing. Now, as far as the facial nerve function, and this, of course, is the one thing that we think we've accomplished with the microscope, because with the microscope you're able to very accurately determine the position of the facial nerve and separate it from the tumor. Now, the Trance-Labyrinthian approach, in our opinion, has the advantage that there is one particular place where you can always locate the facial nerve, and that's at the point where the facial nerve exits from the internal auditory canal and enters the fallopian canal, the labyrinthine part of the facial nerve. Now, once in a while the tumor will extend up along that. If that's the case, then you remove the bone back to the geniculate, and then you can see the normal facial nerve surface. Once you've located exactly where the facial nerve is, then you establish the plane very accurately as to what's facial nerve and what's tumor. And you can do that at that particular point in the lateral part of the internal auditory canal. Then we remove the tumor from the internal auditory canal first. Now, it's very important that you do not push forward on the tumor at any time during the tumor manipulation, because if you do, you will stretch the facial. And this is often a reason why severe facial nerve weakness occurs despite saving the continuity of the facial nerve. So what we do now is to remove the tumor along the facial nerve, and then finally remove the tumor on the posterior aspects along the cerebellum and brainstem. And by removing the tumor first anteriorly along the facial, we can avoid stretching it, and we're able then to very carefully dissect this plane between tumor and facial and do a total removal on our cases. Now, the dissection of the plane is done with a blunt instrument, a blunt hook, and it's very important that enough bone be removed around the internal auditory canal so that this plane can be very adequately visualized. So you must remove at least the posterior half of the internal auditory canal in order to look into the entire canal and be able to very accurately establish this facial nerve plane. Now, using these techniques then, at 1 year post-operatively, we sent questionnaires to all of our patients or those that could come in. We had them come in, and the questionnaire was the main criteria as to the facial nerve function. I think the patient themselves are the best judge of what they think about their facial nerve function. Now, some patients obviously will not feel that the facial is any problem, even though they might have a little weakness, and other patients will feel that even though they have a little drying of the R, that does represent some problem. But in general, what they told us was that out of 180 patients who responded, 83% had normal facial function. So that this then is our current status as far as saving facial nerve. Now, as far as the facial nerve surgery, the results were concerned, actually, at 1 year, we related our results to the size of the tumor. Now, in the small tumors, we were able, out of 20 cases, to save the facial and have normal function in all of them. The medium tumors, it was 85%, the large ones, 81%, and the giants, 63%. So that there is a very definite relationship between our ability to save the facial function and the size of the tumor. And we feel that this speaks very strongly for removing the tumor as soon as it is discovered, rather than letting it continue to grow and watching it with CAT scans for several years. Occasionally a patient wants to do that, but that we have to tell them that if they do, they are having further risk to the facial nerve, because the smaller the tumor, the better our results with the facial nerve. Now, in those patients where we were not able to save the facial nerve function, in other words, the 15% of our patients, we had a partial paralysis. In other words, the patient and we did not feel that it would be improved by further surgery, such as a hypoglossal facial anastomosis. But we did do facial nerve surgery in 30 patients, or 14%. Now, of the total cases where we had paralysis, actually we were aware that the facial nerve either was incorporated with tumor or in some way had to be removed or sectioned at the time of surgery. In that case, we were able to do an intraoperative facial-to-facial anastomosis in 4 of the patients. That's where we reroute the facial nerve and bring the ends together. Now, of the other 2 patients had a hypoglossal facial anastomosis. Now, here is a rundown regarding other complications of these in these 216 patients. We had a spinal fluid leak in 6 patients, aseptic meningitis in 8% of, or 17% of our patients. Now, this is the problem where we have on spinal tap an elevation of the white count, but it's rare that we can grow out any type of bacteria. In one case, I recall, we grew out staph epidermidis, so that apparently the bacterial contamination is usually not real marked, but it is enough to give you this aseptic type meningitis, and it seems to respond to antibiotic therapy. We usually use high doses of intravenous penicillin type medication, and in rare cases we use chloromycetin if it doesn't seem to respond to that. Now, we had post-operative hemorrhage in 2 patients, and we reopened these patients. We have a setup in our operating room, in our intensive care unit, where we can reopen the patient if there is a hemorrhage. And we watch very carefully their vital signs and particularly their conscious level. We allow the patient to respond in the operating room before we remove them out, and that gives us a baseline conscious level. And then if there's any change in that, if the patient becomes more drowsy or develops any vital sign changes, then we're immediately aware of that and we're alerted. We have a setup in the intensive care unit to take out the sutures, remove the fat, and in this way the bleeding can leak out through the wound rather than dissecting into the brainstem or cerebellum. And we can then take the patient back and do a definitive dealing with the hemorrhage or with the operative bed. Now, in this way, we're able to save these patients, and we can immediately open them. That's one of the advantages, as far as we are concerned, of the Trance-Labyrinthian approach, because it is much more easy to open the wound and to be immediately on the operative bed than if we have to go through the suboccipital and retract the cerebellum. Now, in the 6 patients who had the spinal fluid leak, we were able to put pressure dressings on 4 of them and get the leak to seal in that way. In 2 patients, we had to take them back, and we put in a little local anesthetic and put some more fat into the wound, and that way we're able to control them. No, we did not have any patients with cerebellar ataxia, and we think that this represents, even in our very large tumors, the advantage of not having to resect or retract the cerebellum. And if we do any retraction of the cerebellum in the very large tumors, it is compression of the intact dura and the collapsed sigmoid sinus against the cerebellum, and in this way we're able to get to the posterior aspect of the tumor, so that we do not, at this point, have to go either posterior to the sigmoid sinus or ligate it. We, at one time, advocated that, but we don't feel that that's necessary if you do adequate removal of the bone posterior to the sigmoid sinus. We had no patients with 9th or 10th nerve deficits. I have outlined for you our statistics as far as our present results with acoustic tumors are concerned. Obviously, until we can take out these tumors and not increase the neurologic deficit, we have not reached the ideal as far as acoustic tumor surgery is concerned. It is our firm hope that in the future we will be able to remove all tumors and preserve facial nerve function in every case. In addition, we would hope that we could save hearing in a large number of our cases. I think that saving the facial nerve function is a matter of very, very careful attention to the operative details of dissecting the nerve. As far as hearing is concerned, we will not be able to discover these tumors when they are less than 2.5 centimeters in most cases, because it's only when the tumor starts lateral in the canal that it will cause hearing loss while it is still very small. In these cases, we do have a chance at saving hearing. In the larger tumors, I think we will have to develop some way of revascularizing the cochlea before surgery and then take the tumor out if we are to save hearing. This probably will be sometime in the future, but I hope that it will occur someday.